Neurosurgery Part 2 Hydrocephalus Definition. It literally means water head. Abnormal accumulation of excess cerebrospinal fluid within the ventricles and/or the subarachnoid space. Normal CSF circulation, production by the choroid plexus in the lateral ventricles of the brain, then it passes through the foramen of Monro on each side to reach the midline for the third ventricle and aqueduct of Sylvius to the fourth ventricle to the subarachnoid space around the brain and spinal cord. Fourth ventricle has two lateral foramina of Luschka and one midline foramen of Magendie. Absorption inside the skull through the arachnoid villi to the bloodstream. Hydrocephalus in children. Prevalence. Isolated congenital disorder in approximately 1 per 100 live birth, in association with spina bifida in 1 per 1,000 birth. Pathophysiology. Excessive CSF accumulation leads to dilatation of the ventricles and increased intracranial pressure. Usually results from obstruction in the CSF pathway and rarely from overproduction of the CSF. Classification. Non-communicating and communicating. Non-communicating due to lesions which obstruct the ventricular system either at the aqueduct or basal foramina. Communicating due to lesions which obstruct the subarachnoid space. Etiology. Aqueduct occlusion due to aqueductal forking, congenital anomaly, or subependymal gliosis after toxoplasmosis. Arnold-Chiari malformation. The fourth ventricle is displaced caudally below the foramen magnum, leading to impedance of the CSF fluid to the subarachnoid space, commonly associated with myelomeningocele. Dandy-Walker syndrome. Cystic dilatation of the fourth ventricle, obstructing CSF flow. Cerebral malformations, causing arachnoid cysts as encephalocele or hydranencephaly, leading to obstruction of the CSF flow. Neoplasms, mainly in the fourth ventricle, medulloblastomas, astrocytoma, and ependymomas. Clinical picture. If it occurs before closure of skull sutures, the infant presents with macrocephaly, tense non-pulsatile anterior fontanelle, distended scalp veins, and separated cranial sutures. The eyes show the sunset appearance with failure of upward gaze. If sutures have closed, it presents with headache, awaking him from sleep, vomiting, drowsiness, and blurred vision with squinting. Investigations. X-ray of the skull, leading to separation of sutures in infants and the beaten silver appearance in older children. CT and MRI, investigations of choice for diagnosis and detection of the site of obstruction and causative pathology. Cranial ultrasonography through the anterior fontanelle. It's useful for follow-up. Treatment. Removal of the cause, but this is impossible in most cases of congenital hydrocephalus, so CSF diversion using shunts is done. Ventricular peritoneal shunt is the most common, consisting of ventricular catheter, a valve permitting CSF flow in one direction, and a distal peritoneal tube. The valve opens when the intracranial pressure exceeds a certain level, leading to entering of the excess fluid to the peritoneum, absorbed there to reach the systemic circulation. The catheter is inserted through a burr hole in the skull to reach the frontal horn of the lateral ventricle. The peritoneal tube is inserted in the epigastric midline below the xiphoid process. Or we have the ventriculoatrial shunt or ventriculopleural shunt. The commonest complications of shunts: infection and obstruction. Infection. Treatment. By removal of the shunt, external ventricular drain is applied and giving IV antibiotics for 2 weeks. After the subsiding of infection, insert another shunt on the other side of the head. Obstruction. Clinically, the child develops increased intracranial pressure. Treatment. Revising the shunt, replacing the malfunctioning component. Hydrocephalus in adults. Classification and etiology. Non-communicating and communicating. Non-communicating. Tumors or cysts in the ventricles. Aqueduct stenosis. Posterior fossa malformations or tumors. Communicating. Trauma, idiopathic, infection, subarachnoid hemorrhage, and extra-axial tumors. Clinical picture. In acute hydrocephalus, headache, vomiting, papilledema, and drowsiness. In chronic and normal pressure hydrocephalus, gait disorders, memory loss, urinary incontinence, and slowing of thought and action. Investigations. CT and MRI, this of the choice, diagnosis of hydrocephalus and its underlying cause, and overnight monitoring of CSF pressure and perfusion. In cases of normal pressure hydrocephalus, it records bouts of raised intracranial tension. Access is gained through ventricular or lumbar catheter. Treatment. CSF diversion is done by ventriculoperitoneal shunt, mainly ventriculoatrial or ventriculopleural shunts, less commonly, and lumboperitoneal shunt for the communicating variety. Brain abscess. Etiology and pathogenesis. Routes of infection. Direct spread, the majority from paranasal sinuses, middle ear, or mastoid infection. Skull defects, which are acquired, such as cholesteatoma of the middle ear, or congenital dehiscence of the tegment tympani. Hematogenous spread, source primary site from dental or tonsillar abscess, usually causing multiple brain abscesses, commoner in congenital heart diseases with right to left shunt. Post-traumatic, especially if foreign bodies are present. Previous craniectomy, especially in immunocompromised patients taking immunosuppressive therapy for transplantation. Clinical picture: general, low-grade fever, severe headache, resistant to analgesics, neurological, general, symptoms of increased intracranial tension, alteration of conscious level in about 50%, and local, focal neurological symptoms. The formation of a collagen capsule in developing abscess is the single important response which limits the spread of infection to the rest of the brain. Investigations: laboratory investigations, elevated YBCs and sedimentation rate, radiological, CT or MRI, which are the investigations of choice. CT scan is done with and without contrast. MRI is done with gadolinium enhancement. They show single or multiple space-occupying lesion, which is well delineated with enhancing wall. The differential diagnosis of single brain abscess is solitary metastasis or cerebral infarction, multiple abscesses, multiple metastasis, and tuberculomata. Lumbar puncture is contraindicated in cases of brain abscess to avoid fatal conization, and majority of responsible organisms are obligate and aerobes, with 50% of them being resistant to penicillin. The mortality rate resulting from aspiration alone or aspiration followed by excision and primary excision alone are almost similar. The treatment: non-surgical and surgical. Non-surgical indication for abscess less than 1.5 centimeters, antibiotics and corticosteroids. Antibiotics: high dosage of broad-spectrum antibiotics until results of culture and sensitivity appear. The chosen drugs should be able to cross blood-brain barrier. The usual regimen is combination of penicillin G, trimethylprime sulfamethoxazole, and aminoglycoside. Corticosteroids to reduce cerebral edema despite their potential adverse effect on the infection. Surgical treatment: excision versus aspiration, done by using blunt-tipped needle by way of burr hole in the skull. Factors which favor aspiration: multiple abscesses, deeply seated abscess, critical locations such as motor or speech area, poor general condition of the patient. Factors which favor excision: superficial abscess, presence of a foreign body, fungal abscesses which have poor response to antifungal therapy, and finally multilocular abscess, difficult to aspirate all locules. Intracranial tumors, clinical picture: they may be asymptomatic, general impairment of the cerebral function such as amnesia, irritability, confusion, or dementia, headaches in about a third of tumor patients due to increased intracranial pressure or direct stretch of the meninges, evidence of increased intracranial pressure such as headache, vomiting not preceded by nausea and is projectile, not related to meals and occurs in the early morning, blurring of vision with increasing of the pressure, papilledema occurs leading to optic atrophy. Specific syndromes are related to the site and nature of the tumor: hemiplasia in tumors of motor area, aphasia in tumors of speech area, and hormonal disturbances in functioning pituitary tumors such as Cushing's disease, acromegaly, galactorrhea with prolactinomas. General considerations: the term intracranial tumor refers to all neoplasms arising from the skull, meninges, blood vessels, pituitary and pineal glands, cranial nerves, brain tissue, or congenital rest or metastatic tumors. Epidemiology: commonest intracranial neoplasm is metastasis. In more than 20% of all patients with cancer, the brain and its coverings are involved by metastasis and at the same time in the course of illness. In children, brain tumors are the second in frequency to leukemia, representing 22% of all childhood cancers. Classification of intracranial tumors: secondary brain tumors, metastasis commonly from bronchial and breast cancers, and primary brain tumors. Primary brain tumors are divided into tumors arising from glial tissue such as gliomas, astrocytoma, oligodendroglioma, ependymoma, glioblastoma multiforme, meninges, meningioma, nerves, neuromas such as acoustic neuroma, blood vessels, hemangioblastomas, embryonic tissue, medulloblastoma, anterior pituitary, pituitary adenoma, non-functioning adenoma, and functioning adenoma. Maldevelopment, craniopharyngioma such as Rathke's pouch. Investigations: plain skull X-ray, either normal or showing changes due to increased intracranial pressure in the form of prominent convolutional markings, thinning and erosion of dorsum celli, widening of the cranial sutures in infants before their closure. Local changes may occur with specific tumors such as suprasellar calcification in craniopharyngiomas, hyperostosis and skull thickening in meningiomas, widening of the skull base foramina with skull base tumors. CT, IV iodinated contrast is required in 60 to 80% of examinations. CT accurately detects site of the tumor. and its boundaries, showing whether there is surrounding edema or not, any shift of midline structures by mass, associated hydrocephalus, any bony changes, giving an idea about tumor nature, solid, necrotic, or calcified, and consequently its pathology. MRI, contraindicated in presence of metal implants as cardiac pacemakers, aneurysm clips, metallic foreign bodies, and patient support systems as respirators or IV line stands, because the material may move or stop working, endangering the patient's life. Materials made of titanium permit safe MRI examination. CT angiography is the last investigation. Management: if the patient shows signs of compression, urgent dehydration, using diuretics as 25% dextrose or mannitol. Dexamethasone is very useful in treating of edema surrounding brain tumors and restore a comatose patient to consciousness while preparing for surgery. If an intracranial tumor is associated with hydrocephalus, common with posterior fossa tumors, ventriculoperitoneal shunt before or after surgery, depending on patient's general condition and surgeon's experience. Many of the skull-based tumors, which were considered difficult to reach, are now easily accessible by removing as much as possible of the bones of the skull base, face, and ear to minimize brain retraction. CT or MRI-guided stereotactic surgery is done for biopsy and excision of the tumor if deeply seated in the brain, and a head frame is used to facilitate accurate 3D localization of the region, which can then be reached by fine instruments introduced through a burr hole. In cases of malignant brain tumors or metastasis, adjuvant therapy improve prognosis. Radio and/or chemotherapy are supplementary to surgical excision. The most significant finds by examination pointing to intracranial tumors are presence of papilledema, signs of focal damage to nervous system. Lumbar puncture is contraindicated in suspected cerebral tumor because it may precipitate a fetal conization of the brainstem through the foramen magnum. Individual intracranial tumors, metastatic tumors, multiple brain metastasis treated by brain irradiation, solitary brain metastasis, disseminated disease or life expectancy less than 2 months, then brain radiotherapy, while limited systemic disease and life expectancy more than 2 months, if surgically accessible, excision followed by radio, and if the lesion is inaccessible, only radiotherapy. Gliomas, definition: central nervous system tumor, cell of origin, cell of glial origin. Incidence: the commonest of primary CNS neoplasms, including astrocytic tumors, oligodendroglioma, ependymomas, and glioblastoma multiforme. Diagnosis: a biopsy or surgical resection. Treatment: adjuvant radio or chemotherapy is usually needed after biopsy or surgical resection, except for low-grade astrocytomas. Meningiomas. Incidence: 15% of intracranial tumors occurring in 4 to 6 decades, with slight female preponderance. Origin: arachnoid villi, microscopically appearing as whorls of fibroblasts around central hyaline material, calcify, forming samoma bodies. Malignancy defined by frequency of mitosis, invasion of the brain, and metastasis. The common sites are parasagittal sphenoid wing and olfactory groove regions. The tumor tends to produce hyperostosis of the skull. Course: usually long and generally benign. Clinical picture related to those of intracranial mass or seizures. Investigations: CT scan accurate. Treatment: complete surgical removal leading to cure. Pituitary tumors, classification: non-functioning and functioning. Non-functioning pituitary adenomas, incidence: 30% of pituitary tumors seen in 40 to 50 years. Other names: null cell tumors, undifferentiated tumors, and non-hormone producing adenomas. Presentation: usually late until they are very large, leading to optic chiasma compression, which lead to visual field defects. Treatment: microscopic transsphenoidal excision. Functioning pituitary adenomas, classification according to hormones they secrete. Prolactin secreting adenomas, growth hormone secreting adenomas leading to acromegaly or gigantism. Glycoprotein secreting adenomas leading to excess TSH, LH, or FSH. ACTH secreting adenomas leading to Cushing's disease. Some of these secrete more than one hormone as prolactin, growth hormone secreting adenomas. Classification according to the size: microadenomas less than 1 cm and macroadenomas which have larger size. Diagnosis: clinical changes, hormone assessment and radiology, MRI and CT scan. Treatment: excision by transsphenoidal route, whether sublabial or transnasal. An invasive tumor with incomplete excision, radiotherapy. Prolactinoma, incidence: 40% of all pituitary adenomas. Clinical picture: in women, amenorrhea, galactorrhea, and infertility. In men, impotence or maybe asymptomatic. Hyperprolactinemia in presence of macroadenoma doesn't necessarily mean that the tumor is prolactinoma. Mild prolactin elevation, less than 150 nanogram per milliliter can be due to pituitary stalk compression, treatment, bromocriptine, antiprolactin drug, replaced surgery except for specific situations. Surgery of nerves. Anatomy. A nerve trunk is formed of nerve fibers arranged in bundles bound by connective tissue fascia called epineurium. Each bundle is surrounded by connective tissue called perineurium. Connective tissue around individual nerve fibers is called endoneurium. Each nerve fiber consists of central axis slender surrounded by myelin and neurolemmal sheath. Character of peripheral nerve fibers. They may be motor, sensory, vasomotor, or pseudomotor. Divided tracts can regenerate and recover to variable extent depending on the trauma severity. Etiology of nerve injuries. Open injuries, knives, scissors, missiles, and burns. Closed injuries, contusion by sudden direct violence. Compression against adjacent bone by tourniquet or splints. Traction or stretching, such as tearing of the lateral popliteal nerve and forcible adduction of the knee and tearing of the roots of brachial plexus in burst injuries. Fractures and dislocations, contusion, compression, stretch, or laceration by the displaced bone. Ischemia from damage or occlusion of the main artery. Accidental injection of irritant substances as the case of sciatic and radial nerves. Pathology. Neuropraxia, functional block of nerves. Definition. Functional paralysis of conduction, but the nerve is anatomically intact without any organic rupture. Etiology. Minor traction or compression injuries, concussion, and vibratory effect of a high-velocity missile. Pathology. Fibers are intact with no axons degeneration. Clinically, complete motor paralysis, long nerve distribution, patchy sensory loss or even no sensory disturbance at all. Electrical excitability of the paralyzed muscles remain normal. Recovery spontaneously within days or weeks. Axonotomesis. Definition. Partial or complete rupture of nerve fibers within an intact sheath. Etiology. Contusion or traction injuries or fractures and dislocations. Pathology. Damage of nerve fibers and Wallerian degeneration in distal portions of torn axons, leading to complete motor and sensory paralysis. Regeneration of axons across the site of the damage and continues distally to nerve endings at a rate of approximately 1 mm per day, with 2 delays: initial delay for about 10 days and final delay of 3 weeks when axons reach the synapse. Recovery usually complete because the axons remain in their respective neurolemmal tubes. The length of time required for the recovery depends upon the level of the lesion. Neurotomesis. Definition. Partial or complete anatomical division of the nerve. Pathology. Degenerative changes occurring in the nerve as in axonotomesis, but the gap fills with mass of fibrous tissue and regenerating axons known as bulb neuroma. Complete division. Terminal neuroma on the end of proximal segment separated by interval from the atrophic distal end. Wallerian degeneration in the distal segment occurs, and retrograde nerve degeneration until the first node of Ranvier. Complications. Fibers mix in attempts to recovery. Spontaneous recovery is impossible. Poorest in mixed nerve supplying large number of muscles concerned with fine movement as ulnar and median nerves, and in motor nerves which supply large number of small muscles due to maldistribution of the fibers. Best in purely motor nerves which supply few groups of large muscles such as the radial nerve. Clinical picture. Motor effects. Loss of reflexes, whether superficial or deep. Muscle atrophy. Loss of voluntary contraction of supplied muscles, and deformity as claw hand deformity in ulnar paralysis. Sensory effects. Anesthesia. Due to overlapped dermatomes, area of anesthesia is less than the nerve anatomical distribution. Pain. Favorable sign. More common in partial than in complete lesions, and refer to area of cutaneous distribution of injured nerve. Autonomic effect. Causalgia. Pseudomotor effects such as anhidrosis in the denervated part over a large area than the area of the anesthesia. Vasomotor effects. Vasodilatation. Skin becomes red and warm, followed by vasoconstriction for about 3 weeks. Blue and cold skin. Trophic changes. Etiology. Disuse. Sensory loss. Vascular changes. Effect. The skin loses its wrinkles. Smooth, thin, and inelastic skin. Normal resistance to trauma is lost and ulceration occurs. The nail becomes distorted and brittle. Loss of subcutaneous fat. Loss of hair in the denervated areas. Tips of fingers may shrink and taper. Contracture and ankylosis of joints. Progressive bones decalcification, marked in proximal and distal extremities of the phalanges. Investigations. Nerve conduction velocity. Normal nerve conduction velocity is from 50 to 70 meter per second, and neuropraxia doesn't interfere with this velocity. It decreases after neurotomesis, 20 to 40% of normal after 1 month, gradually increases during regeneration. Electromyography, normal at rest, no electrical activity during full voluntary contraction, 500 millivolt recorded, 2 to 4 weeks after complete nerve injury, spontaneous fibrillations, and in complete fibrosis, no electrical activity is recorded. Tenno sign, tapping the nerve leads to tingling sensation at the site of regeneration. Treatment, conservative and surgical. Conservative indications in neuropraxia and axontomesis aim to prevent muscle stretching, preserve joint mobility, and minimize muscle wasting. Measures, splintage, preventing overstretching of the paralyzed, removed at least once a day to permit all joints to be put through a full range of passive movement, physiotherapy to prevent edema and joint stiffness, electrotherapy, minimize muscle wasting and fibrosis, skin protection, because they are susceptible to be injured, surgical treatment indications, open nerve injuries and closed nerve injuries if failure of recovery at a rate of 1 mm per day, failure of progression of Tenno sign, and if there is palpable neuroma, timing of surgery, primary nerve suture indication, clean incised wounds, secondary nerve suture indications, contaminated or lacerated wounds, timing after complete skin healing because nerve suture needs mobilization of both ends and opening new tissue planes, allowing spread of infection. Primary operation is done to approximate divided ends and close the skin. Early healing occurs, preserving fibers orientation and preventing retraction. The technique is general anesthesia with tourniquet, long incision, mobilization of nerve ends, resection of neuroma and damaged parts of the nerve ends using sharp knife, nerve suture, either by epidural repair or intrafascicular repair. Epidural repair interrupted 6/0 proline. Sutures pick up the nerve sheath only, epinurium, and intrafascicular repair passing the sutures through the perineurium using operating microscope. Nerve grafting indication, wide gap which cannot be approximated. The nerves used, small cutaneous nerves, usually the sural or ilioinguinal nerves. Method, nerve is divided into segments which match the size of the defect. Multiple nerve grafts, 2 to 4, bridging the defect looking like a cable, and this is called cable grafting, and it also needs vascularized bed. Results depend on the injured nerve. Radial nerve is the best because it's predominantly motor and there is less chance of maldistribution of the fibers during regeneration. Level of suture, high level injury leads to long recovery duration. Time interval between injury and suture, the earlier the better. Extent of injury, large gaps between cut ends have bad prognosis. Age and patient's general condition, good in children and adolescents. Secondary treatment, operations to remove function when nerve recovery is impossible, such as nerve transfer, taking a nerve or branches of a nerve of less important role to transform them into restore the function of a damaged crucial nerve, tendon transplantation for radial palsy, functioning free flap, arthrodesis of the shoulder for paralysis of the abductors and arthrodesis of tarsal joints for paralytic talipes, amputation of the arm for total brachial plexus injuries and amputation of the leg for sciatic lesions. Late suturing of the injured nerve leads to long period of muscle denervation, leading to muscle wasting and degeneration. Muscle deprived of nerve supply for more than 2 years cannot recover due to irreversible changes in the motor end plates. The idea of the nerve conduction velocity is to measure time which elapses after nerve stimulation at a chosen point to induce muscle action potential. Electromyography is done by inserting a needle in the muscle supplied by the nerve to study, and prognosis of nerve repair in the upper limb, best in radial, intermediate in median, and worst in ulnar nerve. Facial nerve injury. The nucleus of facial nerve is in the floor of the fourth ventricle. Etiology, intracranial lesions, may be supranuclear, nuclear, or infranuclear. Supranuclear, upper motor neuron lesion of lower half of the opposite side of the face only, since occipitofrontalis and orbicularis oculi muscles are bilaterally innervated. Nuclear, the whole face and the thick nerve on the same side are affected, leading to atrophy of facial muscles with crossed hemiplasia, since the motor decussation takes place at a lower level. Infranuclear, paralysis of the same side of the face, together with deafness and cerebellar signs resulting from pressure of a tumor in cerebellopontine angle on the root of the nerve. Cranial lesions, fractures of the base of the skull, middle ear disease, or operations in the mastoid antrum leading to damage of the intraosseous portion of the nerve. In this part, any lesion which affects the nerve also involves the auditory nerve, petrosal nerves, or the chorda tympani. Extracranial lesions, commonly involved by Bell's palsy, probably due to herpetic neuritis, and may follow exposure to cold or air draught. Pathogenesis, swelling within the nerve sheath, extending to stylomastoid foramen, leading to nerve compression within its bony canal. Prognosis: absorption of the exudate usually occurs before the pressure has damaged the nerve permanently, and in about 10% of cases, some degree of paralysis persists. The nerve trunk or branches damaged by injuries, operations such as parodectomy, or malignant tumors in the parotid region. Clinical picture: face. The affected side is flat, motionless, expressionless, loss of forehead corrugation on looking upwards, no contraction on laughing or showing teeth, leading to asymmetry. Eye cannot be closed, and on attempting to do so, eyeball rolls upwards and outwards, leading to corneal ulceration due to exposure. Epiphora from drooping and relaxation of the lower eyelid. Mouth cannot close the lips firmly, cannot whistle or blow. Buccinator is paralyzed, so the food collects between cheek and teeth. Tongue, lesion proximate to entrance of the chorda tympani, 6 mm above the stylomastoid foramen, leading to loss of taste in the anterior 2/3 of the tongue. Treatment: conservative indications such as Bell's palsy. Methods: electrical treatment and massage, maintaining health of the muscle and preventing atrophy. Active facial movements in front of a mirror several times per day. Recovery begins from 3 to 4 weeks and completed in 3 to 6 months. Operative indications: neurotomesis. Methods: if the nerve is accidentally divided, nerve suture, and if the gap is wide, nerve graft using great auricular nerve. If repair is impossible, hypoglossal anastomosis. Hypoglossal nerve is divided and its proximal end is anastomosed to the distal end of the injured facial nerve. In late cases, face asymmetry improved by plastic operation. Hypoglossal nerve usually escapes injury in fractures of the base of the skull, since the anterior condyloid foramen is protected by a bony ridge, and this deflects the fracture towards the foramen magnum. Accessory nerve injury etiology: commonly during operations on the neck, particularly for removal of tuberculous or malignant lymph nodes. Fractures of the posterior fossa involving jugular. Clinical picture: division in the anterior triangle leading to partial paralysis of the trapezius and sternomastoid muscles. Receive additional nerve supply from the cervical plexus. Division in the posterior triangle leads to that the trapezius alone is affected, drooping of the shoulder, tilting of the scapula, and inability to abduct arms about the right angle due to imperfect scapula fixation. Hypoglossal nerve injury etiology during operations for removal of tuberculous lymph nodes or submandibular salidectomy operation may be involved by malignant diseases. Clinical picture: hemiatrophy of the tongue directed towards the paralyzed side on protrusion. Brachial plexus injury etiology: pressure injuries, fractures from the clavicle and shoulder dislocations or attempts to reduce them leads to injury to the medial cord of the plexus, or open injuries, which are rare, by gunshot or stabs in the lower part of the posterior triangle during axillary block dissection. Traction injuries, burst injury in vertex or breech presentations from forceful stretching of the head during delivery. Hyperabduction of the arm under anesthesia, leading to damage of the 8th cervical and the 1st thoracic nerves. Forceful shoulder depression, as when heavy weights fall on the shoulder, leading to damage of the 5th and 6th cervical nerves. Whole plexus injury is rare, and since injury sufficient to damage all roots of the plexus is fatal. Clinical picture: whole plexus type, upper arm type, and lower arm type. Whole plexus type: motor, whole arm is paralyzed. Sensory, anaphobia of the upper limb except for the medial side of the arm down to the elbow. Intercostobrachial nerve is a supply, and for a more limited area on the outer side, supraclavicular nerves supply this area. Horner syndrome, ptosis, meiosis in ophthalmos, and anhidrosis. Upper arm type or Herb Duchenne paralysis, C5 and C6. Motor, policeman or waiter tip position. Limb hangs by the side with the forearm extended and pronated. Sensory, anesthesia over the outer side of the arm, absent if 5th nerve only is involved. Lower arm type or clumps paralysis, C8 and T1. Motor, paralysis of the flexors of the wrist and fingers. Claw hand, paralysis of intrinsic muscles of the hand. Sensory, anesthesia along the inner side of the forearm and inner 1½ fingers. Homer's syndrome indicate high lesion and bad prognosis. And yes, I said Homer's syndrome, it's not Horner syndrome. Treatment: conservative treatment and surgical treatment. Conservative indication: closed injuries. Method: the arm is planted in right-angled abduction, relax the deltoid and spinati, and the forearm being flexed and supinated to relax biceps, brachialis, and supinator. Elevation and massage to control edema. active and passive movements of all joints to prevent stiffness, electrotherapy to maintain tone and nutrition of the muscles, surgical treatment indications, degenerative lesions which fail to recover within 2 months, particularly when neuroma is palpable, operation, remove scar tissue and the nerve ends are freshened, identified and sutured together, prognosis, results are often disappointing, neuropraxia recovers within 3 to 4 weeks, but axonotomesis take very long time and physiotherapy should be continued for at least 2 years. And this concludes our part for the neurosurgery for today.